Welcome all of you for this very good evening. Heavy rains, but the climate is wonderful to say. Today we are having a topic on COVID related cardiology, importance of hematology in COVID, corona attacks on vascular system, and the stalwarts या क्षेत्रातले आपण दिग्गज म्हणतो डॉक्टर हसमुख गुजर, डॉक्टर समीर मेलनकरी सर, डॉक्टर अद्वैत कोथुरकर हे आहेत. I request our dynamic president, Dr. Aarti Nimkar, always fit and fine to say, and she needs no introduction. So I request her to introduce all of the speakers and take over. Thank you, madam.
I welcome you all for this webinar today. We know that the COVID pandemic, we all are very much stressed and under pressure. Also, there is a big confusion about the symptoms, diagnosis, treatment of the COVID-19 infection. Not a definite pattern of the symptoms we see. There are varied pattern of the symptoms. No perfect antiviral drug we found, and we don't have any vaccines till now. So only the thing we have to do is the protection, detection, and early treatment. It is the only goal, and with that we can achieve the reversal of the infection very safely. So today we are having our three eminent speakers, Dr. Hasmukh Gujar, intensive cardiologist, Dr. Samir Melenkari, the hematologist, and Dr. Advait Kothurkar, vascular surgeon. Wish that our heart beat nicely every time, but I must say that that beat should be in the rhythm. And to beat it in the rhythm, we need to help good blood support and the perfect functioning of our vascular system. And for this, our three speakers will guide us towards the using their expertise. We are going further, and I am going to introduce our first speaker, Dr. Hasmukh Gujar. He is an interventional cardiologist, MBBS from the Rural Medical College of the Loni, and he has done the DNB medicine from the Pune Hospital and Research Center of the Pune, and also DNB from there. Now he is having his own heartbeat care center, and he is working as a consultant at Inamdar Multi-Speciality Hospital, Fatima Nagar, Pune Hospital and Research Center, Sadashivpet, and Dinanath Hospital, FC Road, Dindayal Hospital, FC Road. He has attended many conferences and presented papers in the national and international cardiology conference. And I request Dr. Gujar to give his presentation and have his own time.
Thank you, madam, for a kind introduction. Basically, today's topic is quite vast. Both Melenkari sir and Kothurkar sir will also tell that this topic is not a small one. So let's begin with the talk, because we have two more speakers to guide us. Can you see my slides?
Yes, yes.
Yes, yes.
Yes.
So basically, we'll see in next 20 to 25 minutes. If I'm extending more, you can tell me the chat box. I will minimize it. So basically, COVID-19 and cardiovascular system we are going to discuss an acute and long-term implications of this. We all know that what is coronavirus. See, the 2019 novel coronavirus infection is a respiratory infection caused by a virus. SARS-CoV-2 is the name of the virus, we all know that. And COVID-19 is a disease it causes. It is related to SARS and MERS. You'll see that. Causes respiratory symptoms including fever, cough, breathlessness, shortness of breath, and can lead to pneumonia and then further complications of it. It was identified in December 19 in Wuhan city in China and has spread globally. Believed to have originated from an animal host, you can see here, and it's now spreading via human-to-human transmission. And again, as Madam has told, that currently there is no vaccine. Antiviral drugs are available for treatment, but limited data available for safety and efficacy. So with this small introduction of what is coronavirus, just minimize this. Let's see this. We all know that in SARS coronavirus, it had an SARS infection, severe acute respiratory syndrome in 2003, an outbreak. And then in 2012, there was a MERS, Middle East Respiratory Syndrome, which was again due to coronavirus. And now it's a COVID-19 deadly infection. We are all seeing it. So basically, we have seen that it was in 2003, then 2012, and then 2019. Basically, see this is a person who is going to be infected with all these risk factors: old age, chronic pulmonary lung disease, diabetes mellitus, and other cardiovascular diseases. These are risk factors for this. And the SARS-CoV-2 virus has got spikes, S proteins on it. These S proteins, it binds to the ACE receptors on the cell membrane. These ACE2 receptors are present in the lungs, in the heart, blood vessels, and GI tract. Also in nasopharynx, which is a part of GI tract. So when this SARS infection, SARS virus binds to this ACE receptor, and then the person gets infected. This is SARS-CoV-2 receptors and human antigen receptor, person get infected mainly due from the oropharynx, mainly from the respiratory system. And because of all these comorbidities, the infection becomes severe, especially in the older age, and can lead to respiratory distress syndrome, septic shock, metabolic acidosis, coagulation dysfunction, organ failure, and various cardiovascular complications. So basically, SARS-CoV infection, ACE receptors are important, and again, various comorbidities leads to infection of a host, and it can lead to severe infection depending on the patient's profile. So this interaction of COVID-19 with cardiovascular system. Bats are the sources of SARS-CoV-infected virus. SARS-CoV-2 virus may originate from bat or unidentified intermediate host and cross the species barrier to humans. Spike S glycoproteins of SARS-CoV-2 binds to host cell receptor. These host cell receptors are ACE2 receptors, which is a crucial step for virus entrance. SARS-CoV-2 mainly invades alveolar epithelial cells, resulting in respiratory symptoms. They may invade heart directly, or they may involve blood vessels directly also. Host factors can also influence vulnerability for infection and disease evolution. Older patients with underlying disease are vulnerable to SARS-CoV-2 infection and tend to progress into severe complications. The severity in patients with cardiovascular diseases may be associated with increased secretion of ACE2 in these patients compared to healthy individuals. So basically, it binds to the ACE2 receptors, which is crucial for virus entrance, then lead to respiratory symptoms, and then other complications. This slide is very important. Who is most at risk for coronavirus infection? See this. Overall death rate was 2.3%, death rate among diagnosed patients by age group. See, up to 40 age group. If the patient gets infected and he's young, between 10 and 19, or between 20 to 30 age, or between 30 to 39 age, the death rate is just 0.2%. That means only 2% in 1,000 patients, 1,000 COVID patients may die. From 50 to 59, from 40 to 49, it is 0.4%, it's quite less. But as the age goes up more than 50, the death rate increases. Still at 50, it is 1.3. From 0.4, it jumps to 1.3 between 50 and 59. And from 60 age onwards, the risk of death due to coronavirus is very high. It's about 15%. So up to 50 age, it is just 0.2 to 0.4%. But after 50 age, particularly a patient should take care of himself, a person should take care of himself, because the death rate increases with the increasing age. It's very important. And also by the underlying conditions. So if the patient has if the person has none of the diseases, doesn't have hypertension, diabetes, or respiratory disease or cardiovascular disease, the death rate is just 0.9%. Vis-a-vis if the patient has hypertension, it is 6%, and patient with cardiovascular disease is 10.5%. So again, the underlying conditions are very important. So basically age and underlying conditions are very important. If the age is more, the risk of death due to COVID is more. And if the patient has underlying conditions, hypertension, diabetes, chronic respiratory disease, and cardiovascular disease, the risk of death are more. So these two should be very well kept in mind. Coming to clinical presentation, see this typical, like any other infection, any other virus infection, it follows a typical triangle shaped curve, triangle shaped thing. See the mild, about 80% of patients has mild symptoms, mild or pneumonia, and they become normal, they are cured. Severe diseases like dyspnea, hypoxia, or more than 50% of lung involvements are seen in about 15% of patients. And critical diseases requiring ventilation are seen in mainly 5% of patients. So yeah, of these infected patients, symptomatic patients are quite less. Of that, hospitalized patient is less, and death usually occurs in about 5% of patients, 2 to 5% of patients in critically ill patients. See, according to currently available mortality data, the mortality in case of MERS, it was 34%. It was very high mortality in case of MERS. In SARS, it was about 10%. But in COVID, the mortality is quite less, 2 to 4% for COVID-19. So it's less infective as compared to MERS and SARS. But the problem is, though the coronavirus is less deadly virus than the pathogens behind other large scale outbreaks such as MERS, such as SARS, MERS, and Ebola. But the infection with the coronavirus also seems to spread more easily than other diseases, including seasonal influenza. The infection COVID virus spreads more easily as compared to viruses caused by MERS and SARS. So we are seeing a lot of patients, a lot of comorbidities, a lot of deaths. This and calculation of the virus basic reproduction number, that is R0. R0 is the number of people on average one infected person will pass the virus to other. It was 2 to 2.5. As compared, it was less with MERS and less with SARS. So an infected person can infect 2 or 3 persons more. So infectivity with COVID is more as compared to the other disease, though the patient's severity is less and mortality is less. Coming to cardiovascular disease per se, this is again a very important slide, the mechanism of cardiovascular involvement. See, once the SARS-CoV-2 virus invades the cell, it can invade firstly by directly the lung invasion, respiratory system invasion, or it can this virus can directly attack the endothelial cells of vessels or pericytes of vessels. The virus can directly go into the circulation and become metabolically active. It can directly affect the heart. So this virus can affect the heart directly, can affect the lungs directly, can affect the endothelial cells of the blood vessels, or can have a directly invasion into the blood vessels. From this, if it affects the lungs, this results in inflammation. Inflammation results in activation of T cells and B cells, activation of T cells as well as macrophage. Activation of T cells ultimately results in cytokine storm with release of interleukin 6, 7, 22 and 10. So this leads to plaque instability, plaque rupture, both micro and macrovascular complications, and then ultimately acute coronary syndrome. Again, if it affects directly the heart, it can lead to again plaque instability, plaque formation or microvascular dysfunction, and can lead to acute coronary syndrome. And because of inflammation and because of increased metabolic activity and directly effect of the heart, it can lead to fulminant myocarditis or myocardial damage, permanent myocardial damage or fulminant myocarditis, which leads to myocardial dysfunction, damage, and ultimately arrhythmias or heart failure. So fulminant myocarditis or myocardial damage leads to myocarditis, can lead to heart failure, arrhythmias, and ultimately death. So Once SARS-CoV-2 virus invades the body, it can cause acute coronary syndrome by microvascular dysfunction or microvascular dysfunction. It can cause myocarditis, which leads to heart failure and cardiac arrhythmias and may ultimately lead to death because of cardiac cause. So this is very important. What are the variety of clinical presentations of COVID-19? So ST segment elevation is one of the presentation of COVID-19 infection. Initially, when COVID started in India in March, we were unaware of these things and we were very afraid of treating these patients by taking them into cath lab, by taking them into hospitals per se, because all hospitals had a COVID OPD, separate OPD. Patient first used to go to COVID OPD and then come to the casualty or for admission. So most of the patients with escalation MI was rejected at the COVID OPD only because of fear of getting COVID infection to the healthcare workers and others. So ST segment elevation is one of the presentation. Cardiac shock, second presentation. Decompensated heart failure and heart transplant recipients were also at risk of COVID-19 infections and other infections. These two are very common: ST segment elevation, myocardial infarction, and decompensated heart failure. These two are very common. So myocarditis should be strongly considered in patients with chest pain, ECG changes, and biomarkers elevation. Maintaining a low threshold to assess for cardiac shock should be done in this setting. And other things, intra-aortic balloon pump can also be used as a preferred device for cardiac shock due to low management requirement. See, and even in decompensated heart failure, this was being treated as COVID initially, COVID positive. But when this patient used to come late to the hospital because none of the hospitals used to take them because of dyspnea, and they used to come almost to the saturation of 40-50 and required early intubation in casualty. Again, decompensated heart failure, pre-existing cardiac conditions may be exacerbated by COVID-19. Invasive hemodynamic monitoring may be beneficial in selected cases to manage both cardiac and respiratory failure. The use of QT prolonging agents should be closely monitored in patients with underlying cardiomyopathy. So this is very important. Many of the drugs which are used in cardiac or antibiotic causes QT prolongation and further cause arrhythmias and further worsen heart failure. Again, in case of cardiac shock, myocardial dysfunction may be caused of cardiac shock by direct injury by the virus or secondary to cytokine storm. Cardiac shock is also very common. We see patients commonly in casualties. ECMO, we don't use ECMO nowadays because it's a very large device and requires a lot of manpower and a high risk for high risk for infection to the healthcare workers. Again, by medical management used to, ECMO is basically practiced abroad. It's very common in patients with COVID. Again, heart transplant recipient exhibits similar symptoms of COVID-19 infection as non-transplant population and should be aggressively managed. Not going details of this. So, once a patient gets outbreak of respiratory virus infection, there is an interaction with cardiovascular system. If the patient is a primary target without any secondary comorbidities, he can develop hypotension, tachy or bradyarrhythmias, or sudden cardiac death due to increase in ACE levels, proposed mechanism that, or due to sudden surge of pro-inflammatory cytokines and systemic inflammatory response syndrome in these patients. Or else if the patient has significant secondary comorbidities, and with the COVID respiratory infection leads to increase in metabolic demand and decreased cardiac reserve, can lead to such patients become very rapidly unstable and can lead to sudden death and adverse outcomes. See, the spectrum of cardiovascular diseases in SARS-CoV-2 infection, it can lead to viral myocarditis, ACE-mediated viral myocarditis, or coronary microvascular ischemia due to cytokine storm, stress cardiomyopathy due to cytokine storm as well as adrenaline stimulation, tachyarrhythmias because of the same thing. Coagulopathy can lead to type 1 myocardial infarction. Hypotension and hypoxemia can lead to type 2 myocardial infarction. So all sorts of, ranging from myocardial infarction to myocarditis to microvascular disease and cardiomyopathy as well as arrhythmias can develop because of SARS-CoV infection. Not going to, so basically why this occurs, why this tachycardia and LV dysfunction occurs. SARS-CoV infection may direct viral tissue invasion. It may be due to lungs, which lead to hypoxia and myocardial injury, or the virus may directly invade the heart, which can lead to myocardial injury and ultimately tachyarrhythmias. Other mechanism is because of abnormal host immune response. There is a cytokine storm. Cytokine storm, there is a release of various interleukins, of which interleukin 6 is very important, which can lead to ultimately sympathetic stimulation, sympathetic hyperactivity, ion channel changes in cardiomyocyte, as well as if the patient is taking QT prolongation drugs, can lead to increase in QT interval and torsades de pointes. This is very important complication and leads to death of the patient if baseline ECG changes, ECG and medicines are not looked for. It can lead to sudden cardiac death. So definitely abnormal direct viral invasion of tissue invasion of virus and abnormal host immune response ultimately leads to tachyarrhythmias and death. So progression of acute disease in COVID-19. What are the time course? See this, the stage 1 is early infection, then pulmonary phase, and then hyperinflammation. The 3 stages of this. Stage 1 is viral response, lasts for first 5 days. Stage 2 lasts for up to 10 days, and then stage 3 occurs. So in stage 1, there is lymphopenia because of viral response. In stage 2, which is pulmonary phase, is abnormal chest imaging, and maybe patient develops dyspnea, may require oxygen. And in stage 3, there is host response. In host response is particularly important as cardiovascular things are considered, in which there are elevated inflammatory as well as cardiac biomarkers, and all the complications, cardiac complications usually occurs late in the course of disease. They don't occur usually on day 1. If the patient presents on day 1, he usually must be having symptoms for 5 to 7 days or 10 days before he comes to hospital with cardiac event. So cardiac events is a late course of detection. Early detection of the patient with clinical symptoms and COVID positivity is very important to prevent cardiac complications in the near future. See this host response, a viral response, it's a time course. Again, occurs early, the first 21 days, then it takes months for coalescent, and then chronic phase for years. So usually acute myocarditis or ARDS occurs usually within first 3 weeks. If the patient settles, still he can have a delayed myocarditis, or a patient can present with cardiac arrest. Now we are getting patients in between these weeks, between 21 weeks to months. Usually a patient who has recovered from COVID infection presents late after 21 days, after 3 weeks to 1 month, with a maybe myocarditis or with a myocardial infarction. So patients right now we are getting in this coalescent phase. And then also late we can get hyperlipidemia, pulmonary fibrosis, and any other chronic cardiac disease we can get as a late sequelae of COVID-19. See basically after SARS-CoV infection into lungs, see these are alveoli. There is a virus membrane interaction here. Virus replication occurs in the alveoli and virus dissemination. Once the virus disseminates, there is endothelial dysfunction, platelet activation, neutrophil platelet aggregation formation, and then formation of a thrombus. See the platelets goes into the alveoli, causes DIC, platelet consumption coagulopathy, disseminated coagulation, and diffuse alveolar hemorrhage. So this forms the basis of antiplatelet therapy. Now the guidelines say that antiplatelets are not used in case of COVID-19 infection to prevent DVT or to prevent pulmonary embolism. But still, I think so we can, there is a role of antiplatelets in prevention of complications of COVID-19 infection. Early antiplatelet therapy, especially P2-vital antagonist, may be beneficial due to their inhibitory effect on platelet activation and generation of neutrophil platelet aggregates, key mechanism in both thrombus formation and platelet neutrophil recruitment. So definitely antiplatelets have some role in clinical settings. So guidelines say that antiplatelets have no role in prevention of prophylaxis, prevention of DVT or pulmonary embolism, but still they can be effective in some way or the other. Now see, the science underlying COVID-19 implication of cardiovascular system. Initial after incubation period, viral exposure on day 0, symptoms onset. Some patients remain asymptomatic till day 7. Some patients develop symptoms. Some patients require ventilation between day 7 and day 21. And then some patients may recover or some patients may worsen and go to organ failure or death. So basically, cardiac markers, troponins, NT-proBNP, proBNP, and cytokines, cardiac markers, these two cardiac markers usually occurs, increases late in the course of disease, maybe after 10 days to 14 days, late in the course of disease. So a patient recovering from COVID, if he's still breathless or patient is still admitted, should definitely be watched for troponins as well as NT-proBNP, because that patient may develop late heart failure or late myocarditis or late consumption coagulopathy or late vasculitis. So a follow-up of troponins and NT-proBNP in patient who is hospitalized with COVID-19 infection should be done. Clinical course of COVID-19 infection, the incubation period averages 7 days, but can be up to 14 days. There can be asymptomatic, pre-symptomatic, or post-symptomatic viral sheddings, likely contributing to its rapid transmission. Cardiac biomarkers such as troponins, HS troponin, high sensitivity troponin, can be detectable in patients at symptoms onset and it is of prognostic significance. Continued increase in troponin together with rise cytokine predict needs for ICU stay, ventilation, and vascular complications. If the troponin levels continues to rise, it can lead to prolonged ICU stay, ventilations, and complications. These three main features, this is very important things. Three main features should be kept in mind while treating a cardiac patients or treating a COVID-19 patients. Patient with COVID-19 infection may present with cardiac event that can be favored by infection or unrelated. These symptoms like myocardial infarction, estivation MI, non-estivation MI, congestive cardiac failure or arrhythmias, this symptom requires quick management and should not be overlooked due to COVID-19 infection. This is very important. If a patient in this COVID era, starting from March, if the patient presents with cardiac symptoms, the symptoms are completely overlooked. The symptoms are completely overlooked. Patients present with palpitations, heart failure, patient with chest pain, these are completely overlooked. Only the thing the hospital casualties were concerned about is COVID-19 infection. The cardiac things were secondary. The cardiac and the patient used to present, the patient used to worsen in hospital, patient used to get massive myocardial infarction, patient used to die in hospital because of cardiac events, and the main focus was on COVID-19 infection. So this should not be done. All patients should be suspected with COVID-19 infection, but should also be the cardiac events, the cardiac things should also be seen in such patients as early as possible. Infection related cardiac injury can also lead to clinical presentation of cardiac events and should be kept in differential diagnosis. Once a COVID patient comes up, patient becomes detected as COVID positive, then that patient is treated only as coronavirus positive or COVID positive, and other organs are not taken into consideration, or other things are not taken into consideration. That patient is just treated as COVID positive patients. Without the patient can get a cardiac event and patient can get a neuro event, that is not taken into consideration. And so even in hospital settings, there are more cardiac patient die because of more cardiac events, more strokes, and more vascular events. Patient with COVID-19 infection may also present with symptoms of cardiac events such as dyspnea, chest pain, or shock. Even in the absence of cardiac injury, such things can also happen. The patient can have a ECG changes, but his 2D may be normal, his enzymes may be negative. But such patients should also be evaluated for cardiac events. Now, all cardiac patients who come to hospital to casualty should be treated as COVID positive unless proved otherwise. If they have a COVID negative report or the X-ray is clear, doesn't have any fever in last few days, can be treated as, should be treated as COVID positive unless proved otherwise. Ideally, 2 swab tests should be done within 48 hours, should be done, and that should be negative before taking a patient into cath lab for safety purpose. Dedicated COVID positive cath labs, dedicated cath labs who can treat, who can intervene COVID positive patients should be done, should be there to treat emergency suspected or COVID positive patients, emergency suspected or COVID positive patients. So all cardiac patients who are admitted in casualty in hospital should be treated as COVID positive unless we have a definite report and there is no clinical indication of viral fever. Ideally, 2 swab tests should be done within 48 hours and that should be negative to be taken, for the patient to be taken in cath lab. Otherwise, the cath lab personally should be trained to deal with COVID positive patients with minimal exposure to them. Coming to STEMI and non-STEMI, the basic difference is See, STEMI network, if the patient is in ambulance, as the ambulance has gone to take the patient, the ambulance should transport the patient to a 24/7 cath lab available hospital. And the major thing is that major changes have been made that timely primary PCI possible. 60 minutes additional extra delay is now allowed in this COVID-19 pandemic for the patients, for the cath lab to be prepared for the rapid antigen test to be done, and then patient can be taken for PCI. If PCI can be done, definitely we have to fibrillarize the patient. So initially the door to balloon time was just 60 minutes. Now additional 60 minutes has been given for the patient to be prepared, for the cath lab to be prepared, and for the antigen test to be done before taking the patient into cath lab. If the 24/7 cath lab is available, then definitely primary PCI is feasible in a cath lab which is trained to take COVID positive patients. The general recommendation is that only hospitals equipped to manage patients with COVID positive COVID-19 should maintain 24/7 cath lab services for primary PCI. Any STEMI patient should be managed assuming positive COVID-19 status. Perform fibrinolysis only if it is not contraindicated. So fibrinolysis can be done if it is not contraindicated in such patients. And this is the same. Again, in patients with non-installation MI, if the patient has very high risk, then only he should be taken immediately into cath lab. If the patient is at high risk, intermediate or low risk, this can be managed with medicine for 24 hours, get the swab test done, get the antigen test done, all the routine labs done, and if the X-ray and other tests are negative, then you can definitely take the patient into cath lab. Except very high risk patient, you can definitely take them into cath lab with due precautions. Okay, there are a lot of fear in management of hypertension. Initially, when the COVID came to India, COVID started. See, almost 60% of Indian hypertensive patients are on ACE inhibitors or ARBs. Unless contraindicated, antihypertensive medications, including ACE inhibitors and ARBs, should be continued in COVID patients who are at home isolated or hospitalized patients. All the guidelines says that to continue ACE inhibitors and ARBs in hypertensive patients who are taking it. So initially there was a lot of fear that to change the medicine from ACE inhibitors or ARBs to some other medication, maybe beta blockers or calcium channel blockers. But all the guidelines says that ACE inhibitors and ARBs should be continued even if the patient is COVID positive, he is taking home, he is home isolated or has been hospitalized. See, this self-isolated hypertensive patients continue treatment with antihypertensive medications according to ESC guidelines. No need to adjust medications or to stop ACE inhibitors or ARBs because of COVID-19 pandemic. It's very important. And in hospitalized patient, unless there is contraindication or hypertension, you should continue ACE inhibitors and ARBs if the patient are taking these medications. See, there was an article in circulation which said that the death rate in patients who are taking ACE inhibitors and ARBs was less, 3.7%, as compared to patients who was not taking ACE inhibitors and ARBs, it was 9.8%. So definitely ACE inhibitors and ARBs should be continued and they offer some protection in patients with COVID-19 interval. Coming to QT interval, see, before starting medications, antiviral drugs or HCQS or azithromycin or any other treatment for COVID, maybe treatment for arrhythmias, a baseline ECG should be done mainly to see QT interval and corrected QT interval. In males, the QT interval is less than 440 and in females, the QT interval is less than 460 milliseconds definitely. But we should not fear if the QT interval is less than 500. Up to 500, definitely we can give medications safely. See this algorithm. Consider no ECG before start therapy if recent baseline ECG available with QTC less than 500 milliseconds and no history of structural heart disease, arrhythmias or syncope, no history of acquired or congenital long QT syndrome and no bradycardia. If there is bradycardia, the QT prolongs. So if there is no bradycardia, no structural heart disease, arrhythmias or syncope and QTC, corrected QT interval is less than 500 milliseconds, you can start the patient on therapy. If ECG is performed, or if QTC is more than 500 or 550, if the QRS field is more than 120, remember the 500 letter, then what to do? If QTC is less than 500 milliseconds, then definitely start treatment if there are no other comorbidities and no bradycardia. If the QTC is more than 500 milliseconds, then evaluate risk benefit of COVID prolonging drugs treatment. If the risk outweighs the benefit, then don't give QT prolonging drugs. And if it is necessary to give in COVID positive patients QT prolonging drug, then definitely give with the monitoring of QT interval. For suppose if the baseline QT interval is less than 500, you can start QT prolonging, you can start drugs and see, repeat the ECG after day 1, on day 2 or day 3. And if the QT has not prolonged more than 60 milliseconds, you can continue giving the medication. If the QT prolongation is more than 60 milliseconds from the baseline, you need to stop the drug. Evaluate risk benefit of, if started, put patients on telemetry or mobile ECG or daily ECG if no telemetry is available. Correct all modalities or modifiable QT prolonging factors in all. Concomitant QT prolonging drugs stop unless really needed. Keep potassium more than 4.5. Give a routine magnesium supplementation to keep magnesium level more than 2 and avoid bradycardia to less than 50. If all this, if the start, then you can start COVID-19 medications in these patients. If there is no bradycardia, the potassium is normal, magnesium is normal, and there are no other QT prolonging drugs in that patient, and QTC interval is less than 500. Corrected QTC is less than 500. You can definitely start COVID medications. After starting the medications, ECG after day 1. See for the ECG after day 1 or day 2. If QT is less than 500 or delta QTC is less than 60, if the QTC interval has not increased more than 60, no further ECGs are needed. If QT interval is more than 500 or delta QTC, change in QTC from the baseline is more than 60, then you definitely reconsider the treatment or change the treatment or do regular ECGs to see the QT interval. Not going into details of the side effects of medications. See, these are important. Antibiotics, what are the things that affect QT intervals and causes arrhythmias? So antibiotics, macrolides, azithromycin, and quinolones, they prolong QT interval and cause arrhythmia. So baseline QT interval should be noted in these patients, and concomitant use of azithromycin and hydroxychloroquine usually should be avoided in such patients. Antiarrhythmic drugs like amiodarone, diazepamide, quinidine, amiodarone, and sotalol again causes QT prolongation, should be kept in mind, should be minimized. Anti-diabetic drugs, HCQS lower sugar level. So if a patient is taking HCQS, then anti-diabetic drugs should be monitored or sugar level should be monitored. Beta blockers, again HCQS increases drug levels of beta blockers, interacting with its metabolism at higher doses. So again, if the patient is taking beta blocker, the heart rate and QT interval should be monitored in such patients. And then digoxin, again HCQS increases digoxin levels. Yes. I think so. Milind Krisel will discuss more on antiplatelets and anticoagulants. I will discuss in short. If a COVID positive patient is already taking antiplatelets or anticoagulants, maybe he's a post-plastic patient, he has got atrial fibrillation, has got a DVT or pulmonary embolism, and now he has come positive, then he should continue his antiplatelets and anticoagulants. This should be continued even if he comes positive. Routine use of antiplatelet drugs in a COVID positive patient is not recommended. If a COVID patient come positive for COVID and he is not on any antiplatelets, there is routine use of antiplatelet is not recommended, should not be given. Use of anticoagulant like heparin and NOACs should be used in high-risk COVID positive patients as prophylaxis against DVT and pulmonary embolism. In the patient who are home quarantine, in non-hospitalized patient with COVID-19, routine use of measurements of coagulation markers like D-dimer, prothrombin time, platelet count, fibrinogen, and routine use of anticoagulation and antiplatelet therapy should not be initiated for prevention of venous or arterial thrombosis. According to this is according to guidelines, but usually we see that most of the patients for home quarantine with COVID-19 usually receives maybe aspirin or maybe Novax in form of maybe dabigatran or rivaroxaban. But ideally, in a non-hospitalized patient with COVID positive patients, the routine use of coagulation markers as well as routine use of antiplatelets and anticoagulants is not recommended. Again, in hospitalized patients, a universal strategy of routine thromboprophylaxis with standard dose of heparin or low molecular heparin should be used after careful assessment of bleeding risk. Usually LMWH is preferred. The incidence of venous thromboembolism is about 27 to 30% in hospitalized patients with COVID positive. Usually in ICU patients, the incidence of venous thromboembolism is very high, and such patients will receive prophylaxis for DVT as well as for pulmonary embolism. Now, D-dimer is usually done in almost all patients. If the D-dimer comes positive, it doesn't mean that he has pulmonary embolism. It's very non-specific. See, this D-dimer as a marker for diagnosis of venous thromboembolism is very unreliable in COVID patients. But elevated D-dimer in COVID patients is a marker of very poor outcome. We have seen patients with D-dimer more than 10,000 and the patient usually worsens. Again, if there is a high suspicion of venous thromboembolism, and if the CTPA can be done, CT pulmonary angio can be done, it should be done. Otherwise, bedside ultrasonography for looking for DVT and well as 2D echo for pulmonary embolism should be done. Routine screening of patients for venous thromboembolism using a bedside Doppler of lower extremities is not recommended based on just D-dimer levels. Again, in post-discharge patients, the risk of hospital-associated venous thromboembolism extends up to 6 weeks post-hospital discharge. At least 60% of all venous thromboembolism events in medically ill patients occurs in post-hospital discharge period up to 3 weeks. First 3 weeks, and then incidence increases fivefold, and there is a fivefold increased risk of fatal pulmonary embolism. So all patients who are admitted in hospital, usually in ICU, has an increased risk of DVT as well as pulmonary embolism for up to first 3 to 4 weeks post discharge and should be treated accordingly. Not going details. Last few slides remaining. Again, there is an increased risk of pulmonary embolism in such patients. What are the risk factors? Male gender, elevated C-reactive protein, and time from symptom onset to hospitalization. The patients get admitted to hospital late. Again, the incidence of DVT, venous thromboembolism, the arterial events increases as compared to patient gets admitted earlier in hospitalization. And what are the protective factors? Anticoagulation with therapeutic doses before it is after admission, and anticoagulation with prophylactic doses before admission. It should be there. So these things should be kept in mind. Coming to last 1 or 2 slides. People of all ages can be infected by coronavirus. However, the virus poses a particular risk to people over age of 60 and those with underlying medical conditions including cardiovascular disease, hypertension as well as diabetes. To avoid infection, we recommend to continue to take medications and advise medical advice. Secure a 1 month supply of your medical or longer if possible, because sometimes the medicine is not available. If there's home quarantine patients, they can't go outside. There's a lockdown. Keep a distance of at least 1 meter. And wash your hands regularly with soap and water for at least 20 seconds and stay at home. And coming to conclusion, patients with cardiovascular diseases have high incidence of severe COVID-19 infection. Usually patients with cardiovascular disease, we allow them to stay at home, to be home quarantined and go minimally in the crowded place. Contrary, patient with severe COVID-19 infection should be considered as a potential candidate for cardiovascular events. The symptoms, chest pain, dyspnea, angina should be taken into consideration, and they should not be just treated as a routine COVID-19 virus infection. All patients admitted with cardiac event should be considered as COVID positive unless a swab test or antigen test is done or the X-ray is clear and the markers are normal. Interventions in patient with non-estimation MI as well as estimation MI should be done uh, only if clinical condition demands. If the patient has ongoing angina, failed thrombolysis, cardiogenic shock, then only you take the patient in cath lab. Otherwise, you manage the patient with medications, with thrombolytic agents till the patient is stabilized, till the swab reports come or COVID is excluded, and then you can take the patient safely in cath lab. Elective cardiac procedures like opening of CTOs, doing of wall replacements, or doing of cardiac surgery should be deferred or should be taken into consideration only after COVID test and a 14 days quarantine period. Antihypertensive medications, specifically ACE inhibitors and ARBs, antiplatelets and anticoagulants should be continued. If the patient is on these medications, he should continue these medications. And appropriate prophylaxis for DVT as well as venous thromboembolism should be taken in hospital pre-discharge as well as post-discharge. Thank you. I think so. This was the last slide. I think so. Hello.
Dr. Sancheti.
Yeah. Thank you very much for a very excellent and lucid presentation.
Fast because again time had extended. Question and answers, we'll take it last.
Yeah, we'll take it last. So I request our President, Dr. Arti Nimkar, Madam, for taking up a second lecture for Dr. Samir Melankari, sir. She will introduce Sir. Nimkar, Madam.
Yeah.
Madam,
thank you, Dr. Guzar, for your lucid presentation. It is a very in detail. You have given the idea of the respiratory and cardiac evaluation in the COVID infection. Now our second expert is Dr. Samir Melankari. He is a MBBS from Bharati Vidyapeeth Medical College, and he has done his MD in BJ Medical College, Pune, and DM Hematology, Clinical Hematology in Christian Medical College, Vellore. And he has been the principal investigator in the numerous international and clinical trials. And he is a consultant hematologist and head of the Department of Hematology in Dinanath Mangeshkar Hospital. And he established the blood and marrow transplant unit at this hospital. A regular transplant program has been established in Dinanath Mangeshkar Hospital by him. And he performed the first unrelated donor transplant in Pune. And he is instrumental in organizing a state-of-art apheresis center. Apheresis, everybody knows that the separating the blood components and using for the specific indication. And he has established that in the Dinanath Mangeshkar Hospital Blood Bank. And his visions for the future is to establish the latest techniques and therapies in the hematology and bone marrow transplantation at the affordable prices and for the people in and outside the Pune. Welcome, Dr. Samir Melankari, and we are waiting for your presentation.
Sure. So my topic is hematology and COVID infection, and you might be wondering what a hematologist has got to do with COVID-19 infection, and we will see soon enough. So COVID-19 is like a chameleon. It is a great mimic of multiple diseases, and this is what we are now getting to know. I think the most important mistake which people made, which doctors made when this epidemic came in, is that it was thought to be akin to the previous pandemics of respiratory viral infections such as H1N1, which we're all used to, 2009 and 2015, and everybody knows that H1N1 is a lung-specific respiratory illness. You have infection, you have ARDS, and it doesn't disseminate to other organs. Similarly, with the MERS and SARS, it is the same. People made that mistake of treating it, assuming that this was only a lung-specific illness and only oxygen therapy, ventilation, etc., were the cornerstones of treatment. But as we can see here, it apart from causing the lung infection, it can also cause a lot of systemic issues. It can cause cardiac injury. It can cause hematological issues. It can present with diarrhea, and we'll see what else it can do. So the course of COVID infection, asymptomatic stage initially, then the non-severe symptomatic stage, and then the severe respiratory inflammatory stage. Clinically, you can classify it as mild disease with no pneumonia, moderate with symptoms of fever, respiratory tract inflammation, and imaging showing pneumonia, and severe where one or more of the respiratory distress criteria are present, RR more than 30 per minute, oxygen saturation less than 93, and the PaO2 to FiO2 ratio less than 300. These indicate severe disease, and critical is when you require ventilatory support and you have multi-organ failure and shock. Of people suffering from COVID-19, 20% will develop respiratory insufficiency, out of which ultimately 5% will require invasive ventilation. And the mortality, as we know, is about 2% worldwide. Coming to COVID and hematology. So this can be divided into issues on the blood cells, the immune system, and the coagulation system. And coming to changes in the blood cells. So this was the first, one of the first publications in March 2020 from China, which showed what all can happen in the blood. So these are the things that can, these are the changes that you might see in a hemogram of a patient. Hemoglobin is most often normal or slightly reduced. The WBC count is normal or mildly reduced. Neutrophil count may be normal or increased, but the most important factor to be noted is that the lymphocyte count. So when you look at the hemogram of a patient with COVID infection, your eyes must immediately go to the lymphocyte count, because severe lymphopenia can correlate directly with the intensity of the infection. You know, the severity of the complications you can relate to when you look at the lymphocyte count. So somebody who's got a very good lymphocyte count or a normal lymphocyte count, you know, you can sort of assume that this patient is probably less likely to do poorly as compared to somebody who's got very severe lymphopenia. A slight decrease in the eosinophil count is seen, and thrombocytopenia. Anemia is, so, you know, in COVID infection, we know that viral infections are in general known to stimulate autoimmune manifestations just after the, you know, when they stimulate the immune system, the lymphocytes, they can induce autoimmunity. Similarly, in COVID-19 infection, a lot of autoimmune manifestations are seen, particularly one of these can be autoimmune hemolytic anemia, which could be one of the causes of anemia in a patient. Thrombocytopenia, in majority of publications that and the patients that we see, we've noted that thrombocytopenia is generally very mild most often, right? So these are those are the platelets that you're seeing. These are the platelets. This is the lymphocyte, and these are the red blood cells. So most often the platelet count drops to something like 80,000, 90,000, about 1 lakh or so, but generally never as severe as what you see in dengue infection. But having said this, there are occasional case reports, even we have seen, where the patient develops sudden severe thrombocytopenia, and these are usually just like we see in dengue, and these are probably a manifestation of an autoimmune reaction, an ITP, which develops transiently in response to COVID-19 infection, and this can be seen in the acute stage of the infection itself. Mechanism of thrombocytopenia in COVID-19 infection. So this could be multifactorial. One, the cytokine storm that it induces will cause bone marrow progenitor cells to be destroyed. They can directly affect the stromal cells and therefore cause hemopoietic marrow dysfunction and therefore decrease platelet production. It can induce an ITP by inducing platelet immune complexes. And then the lung injury which it causes can lead to microvascular thrombosis within the lungs and therefore platelet consumption within the lungs. This is a megakaryocyte with decreased platelet, hardly any platelets coming out from this megakaryocyte. Okay, and this is something which has been reported, transient appearance of EDTA-dependent pseudothrombocytopenia. So as you know, what is EDTA-induced platelet agglutination? When you collect the blood sample of a patient in EDTA, sometimes there is a change in the antigenicity of the platelets because induced by the virus, and therefore EDTA causes the platelets to clump. So in vivo, the platelets are normal. When you collect them in EDTA, they tend to clump, and therefore when you look at EDTA, when you run the sample on a cell counter, you might see that the platelet count is very low. But when you look at the smear, you'll realize that there are lots of platelet clumps in the patient circulation, and this is known to be induced by COVID-19. Slight changes in neutrophils. You can see hyposegmentation of neutrophils and a very hypergranular cytoplasm. This is quite typical of typically seen in COVID infection. This is an eosinophil and this is a neutrophil. And eosinopenia is one of the manifestations of COVID-19 infection. Okay, coming to lymphopenia. So what happens when you have, I'll just give you a small, account of how the infection happens. So you have the virus enters the lungs, enters the alveoli, and it first meets the alveolar macrophages, right? So the macrophages will engulf the virus and break it up into various peptides and present these antigenic peptides to the CD4 lymphocytes, which are present in the circulation. These CD4 lymphocytes then will go and activate the CD8 lymphocytes. They will also activate more CD4 lymphocytes and B lymphocytes, and then they will trigger this cytokine, this sort of immune reaction. Now, the cells that are really exhausted in COVID-19 infection are the CD8 lymphocytes. So the lymphopenia that you see is because of CD8 lymphocyte exhaustion. It's not as though these lymphocytes are destroyed by the virus, but for some reason, there is an extreme consumption of these CD8 lymphocytes in this process, and the marrow is not able to cope with the demand. And therefore, there is a lymphopenia. There is some drop in the CD4 cells as well. And after a while, once the B lymphocytes are activated by the CD4 cells, they will then start producing the anti-COVID antibodies. So this is a hypothetical pathogenesis of COVID-19 infection where this is the CD8 count. In the beginning, it's high. That's the B cell count. And gradually, as the disease progresses into severe phases, these tend to drop. And similarly, the biomarkers of inflammation, as well as the D-dimer, they tend to rise. Right. So this is just a paper which suggests which is shown in detail what the peripheral lymphocyte substrate alteration can be. Atypical lymphocytes, as you see in infectious mononucleosis or the virocytes, are also common in this infection, and you can see these dark blue cytoplasm and angry-looking lymphocytes are seen in the peripheral blood. They indicate a viral infection. So a neutrophil to lymphocyte ratio or lymphocyte to C-reactive protein ratio have been shown by some people to correlate with the disease severity in COVID-19 infection. Coming to biochemistry, you have decreased albumin. It's an acute phase reactant, so albumin will drop. And liver enzymes can increase. Bilirubin can increase mildly. Creatinine can increase creatinine phosphokinase, increase LDH, increase myoglobin, CPKMB, and most importantly, increase cardiac troponin. Coronary injury, I can't discuss this anymore because it's already been discussed. And the most importantly, you have a severe cytokine storm in COVID-19 infection, and which leads to a marked inflammatory response. This is not something which we see in any viral infection per se, right? We know that there is a condition called hemophagocytic lymphohistiocytosis, which is induced by many infections, including predominantly viral infections. So HLH is known to be induced by infections, but COVID-19 per se, in almost every person, it induces a plethora of cytokines. And so you have a high ESR, CRP, procalcitonin. Procalcitonin, of course, is secondary to if you have a bacterial infection. Increased serum ferritin, and various interleukins. Ferritin and interleukin-6 are two markers, simple markers, which can sort of reflect what's happening in the body, how highly the cytokines are increased. You can't check all of them, but IL-6 and ferritin are good markers for this. So a high ferritin more than 1000 and a high CRP more than 40 tend to indicate that there is a high risk of infection or ongoing tissue injury and failed treatment response. IL-6 also has both systemic and local effects on the body. And we know that there is an anti-IL-6 treatment, tocilizumab, which may be effective in some patients with IL-6 with COVID-19 infection. So this is a severe prothrombotic disorder. In fact, there are people who have described COVID-19 infection, if you want to define what happens in it, that it is a disease which induces disseminated microvascular thrombosis with lung as the epicenter. Right, so people believe that because of the hyperinflammation, you tend to have microthrombosis, and the entire pathophysiology in the lungs as well is related more to microvascular thrombosis impairing gas exchange rather than actual damage to the alveoli. The actual cytopathic effect of the virus may not be as prominent as the microvascular thrombosis. But this again is debatable, and probably it differs from patient to patient. So increased D dimer is one of the markers of the thrombophilic state. So if you have a high D dimer at presentation, it indicates that there is a much more severe sort of microvascular thrombosis in the patient. And this is a study which showed the high D dimers tend to correlate with increased mortality in untreated patients, of course. This is so to summarize this this aspect. Lab findings, you'll see decreased lymphocytes, increased ferritin, increased cardiac troponin I, and increased IL-6 and D dimer. Coming to the coagulation parameters. So COVID coagulopathy consists of major artery thrombosis, venous thromboembolism, lung-specific vasculopathy, thrombotic microangiopathy, and antiphospholipid syndrome. All right. So these are all various papers which showed later on in the beginning, people thought it's a lung infection. Later on, people realized that, you know, there are a lot of changes which happen in the blood, and there are a lot of papers, flurry of papers which came in showing, focusing on this aspect. Right. DVT. So deep vein thrombosis is one of the presenting manifestations of COVID-19 infection. Sometimes you may have minimum lung symptoms, but you present with a DVT and you do a swab test and you realize you're COVID-19 positive, and therefore DVT can of course lead to pulmonary embolism. Cardiac issues, which has been discussed, stroke. So major arterial stroke. Sometimes we've had patients who have recovered from infection, the lung pathology is improved, they have gone home and then they have come back with a stroke, or patients have presented directly with a stroke and then realize that the patient has COVID-19 infection. Advait will speak more on this. We have patients who have presented directly with limb gangrene as the manifestation of COVID-19 infection. Acute aortoiliac and mesenteric arterial thrombosis as presenting features of COVID infection. And the lung-specific COVID vasculopathy. This is a novel pulmonary specific vasculopathy. It is a pulmonary intravascular coagulopathy, but this is not DIC. Okay, in DIC you have a diffuse injury to the vessel wall. You have exposure to tissue factor, and then the coagulation factors are all activated and consumed, and the clots are present widespread throughout the body. This is not what happens here. There is just an increase in the there is an injury in the lung, in the endothelium of the lung, and that causes local thrombosis. D dimer will be high in these patients, and it correlates with the severity of the vasculopathy. There is some evidence to show that there is a racial susceptibility to this, and LMWH will definitely reduce these findings. So this is not classical DIC where you see a low fibrinogen. Here you'll see a fibrinogen is often normal. PT is often high without changes in the PTT. Platelet count, which is markedly consumed in DIC, is often normal to slightly high or slightly low. Bleeding is rare. And this is a gentleman who has done an in-depth study of the pathology. He studied the histology of the affected organs, predominantly the lung, and he has documented that most of the pathology is actually see capillaries with fibrin deposition. The type 2 pneumocytes are affected. There are hyaline membrane formation. These are virus particles documented on electron microscopy in the lungs. Myocardial inflammation, epicardial inflammation, and thrombi in the epicardial vessels, and microthrombi in these organs. Viral myocardial particles. And in the brain, similarly, you see infarcts and hemorrhage and brain microthrombi. Virus particles are seen within the brain parenchyma, the vessels of the brain as well. The other manifestations which we see is called thrombotic microangiopathy, right? So this is because of activation of complement by the virus. And this again is not DIC. This is you will not have elevation of the parameters that you see in DIC. And as treatment differs, the future research will tell us whether anti-complement drugs such as eculizumab, they've been shown in some patients to have worked extremely well, where the complement activation is completely stopped, and therefore the patients who were who were very sick were actually cured with eculizumab, but this needs more research. This is just to show that COVID causes inflammation and activation of complement, and therefore can induce a microangiopathy. And the antiphospholipid antibody syndrome, we know that antibodies to phospholipid, which is one of the components of blood coagulation, is known to cause thrombosis, both arterial as well as venous, as well as microvascular thrombosis. And there are papers which have shown that there is an amazingly higher incidence of antiphospholipid antibodies induced by COVID-19 infection. And these patients would again present with the various kinds of thrombosis. So just to go through it once again, there is endothelitis, there is vascular thrombi, there is inflammation, there is cytokine storm, and there is hypoxia. Right. So COVID-19 infection induces marked consumption of CD8 lymphocytes, leading to lymphopenia, correlates with the severity of the illness, remarkable activation of inflammation, hence thrombosis, and oxygenation, anticoagulation, and steroids form the backbone of the treatment. You then tend to wonder whether COVID-19 is actually a hematological disorder, right? Regarding, this is my second last slide, regarding what Hasmukh mentioned about treatment and anticoagulation. I won't discuss about the antiviral drugs because that's not the province of my talk. Regarding the anticoagulation, you cannot make standard guidelines. If you look up the International Journal of Thrombosis Hemostasis, if you look at the American Society of Hematology guidelines, British guidelines, they all just recommend, but the centers, the treating doctors, treating centers have to make a policy for their hospital, what they're going to do, and nobody can be right or wrong. Whether you want to use aspirin, whether you want to use LMWH, what dose is, it can differ so widely that one policy cannot fit all patients, right? So, but what we at Nanak Mangeshkar Hospital are doing are that for all patients who are hospitalized, they are all on aspirin. Contrary to what Hasmukh mentioned, is our policy to give aspirin only because we see a lot of arterial events. Also, we see a lot of myocardial infarcts as well, and therefore we feel that while they are admitted, we put them all on 75 milligrams of aspirin, and also if they are not requiring oxygen. So it is recommended that for a non-severe disease, you use a prophylactic dose of low molecular weight heparin. And if for a severe disease, you use a therapeutic dose of low molecular weight heparin. So how to decide whether it's a severe disease or not? One of the simple things is that if the patient is requiring oxygen, it means it's a severe disease. In that case, we put the patient on enoxaparin 1 milligram per kg twice daily. You can also use one of the newer anticoagulants. If the patient is not requiring oxygen, we give 1 milligram per kg of enoxaparin once a day, which is a prophylactic dose. We don't use a blanket small dose of 40 milligrams. We prefer to use a 1 milligram per kg. So if the patient is 80 kilograms, you can't use 44 milligrams of enoxaparin for that patient. We would use 80. And aspirin for everybody who is admitted in the hospital. At the time of discharge of the patient, we do a D-dimer. And if the D-dimer is below 1,500, then we put the patient only on aspirin for the next 4 weeks. If the patient has a D-dimer of more than 1,500, we put the patient on Xarelto, which is a newer anticoagulant, in a prophylactic dose of 10 milligram once daily. So that is our policy. As far as cutting down the inflammation is considered, we know steroids work. It should be used appropriately, not for every patient for the sake of just because he's diagnosed as COVID-19 infection. You can't just put everybody on steroids. You can't put everybody on the antiviral. So we choose which patient, whoever has a sort of is symptomatic, seems to have hyperinflammation, more severe disease, we use steroids in these patients. Okay, thank you. With that, I come to the end of my talk.
Thank you, sir. Talk, I would say, was really wonderful. Nice presentation. and we came to know about a lot of hematological disorders. And as you said, is COVID hematological disorder? We feel it is, as you say, it is a multifactorial approach, whether to give antiviral drug, whether to give anticoagulants, a bit complicated, but you explained in a very simple way. Thanks a lot. And if there are any questions, I'll just see. Are any questions in chat box?
Yeah, it's cardiology related.
Yes. One question, I think.
Two, I have answered one.
Yeah. What a general practitioner should do proactively to prevent cardiac complications in COVID-19 positive patients? Please guide the dose of aspirin. Second.
I would say if for a patient who is home quarantined, he sort of tends to be when in a hospital you're on a bed and you tend to move less. When you are in the at home, you tend to sort of move more, and these are generally lesser sort of lesser severe patients. So therefore, it is debatable. We would not anticoagulate such a patient unless he has in general a higher risk of developing thrombosis. But for cardiac this thing, if you feel that he is on the older side or has a has other comorbidities, obesity, etc., which could lead to a cardiovascular complication, yes, you put them on low molecular aspirin 75 milligram once daily. You would give it for a period of 4 to 6 weeks. I feel that it is safer to give than not. So your threshold for giving aspirin should be quite low.
I definitely also think the same. Usually till now we are giving aspirin to all IPD patients. Definitely we are giving aspirin as well as normal heparin or NOACs. But for OPD patients also, if they are at high risk, they are old age, more than 40, 45, they have hypertension, diabetes, definitely aspirin at least 75 milligrams should be given to them for at least 4 weeks if they are not taking it. If they are already on aspirin, they should continue it. If they are not on aspirin, they should start aspirin at least 75 milligrams. And sometimes these patients who are home quarantined, they also receive steroids, oral steroids. For some other things, they receive steroids also. Many of them are steroids. So monitoring of sugar, monitoring of other coagulation parameters, as well as taking aspirin is important for them for at least 1 month. But the guidelines, what the contrary say, there are a lot of debatable guidelines on the role of aspirin for patients who are home quarantined, as well as for the patients who are home quarantined versus patients who are hospitalized. Say that definitely low molecular heparin or NOACs should be given to prevent DVT or pulmonary embolism. But the role of aspirin, they have seen that it's quite debatable. But in our settings, we definitely use aspirin 75 milligram daily for at least 1 month period to prevent maybe complications of arterial events.
Any gastric complications about aspirin known?
75 milligram aspirin will not cause any gastric complications. Usually, if the patient is allergic to aspirin, then we can definitely switch over to clopidogrel or maybe a small half dose NOACs in such patients. But aspirin 75 milligram will not have any gastric complication.
I have advised NOACs even for several of my home quarantine patients on a case-to-case basis. So unless they're like very young and very less likely to develop thrombosis, if they're on the older side, it is definitely worth putting them on NOAC as well.
If the patient is home quarantined, for Bilinkar sir, if the patient is home quarantined and has a D-dimer of more than 1,500 or 2,000,
yes, of course you should. Yeah.
Should we give NOACs to them?
Yes, you should. It is safer to do that. Yes.
I just went through guidelines. They said aspirin is quite debatable. Not to aspirin as a prophylaxis for DVT or pulmonary.
Yes, true. So aspirin is predominantly for arterial events.
Arterial events.
Yeah. If the dimer is higher, can we keep that patient in the home quarantine? Or can?
Yes, you can. The home quarantine depends on what his other parameters are. Especially the SpO2, etc. The SpO2 probably is the most important. If that is okay, and other parameters don't warrant hospitalization, they can very well be kept at home on a anticoagulant.
What we have discussed with all patients who have home quarantine or hospitalized with COVID positive, should at least be on aspirin for 1 month. Preferably 75 milligram.
Okay.
That should be the take-home message with aspirin.
Thank you. Should we go ahead, President Madam?
Yeah, I think the DigiShield people are somebody.
Yeah. So I think we should introduce Mr. Deepen Mehta from DigiShield. His topic is digitalization of the medical records and its importance. DigiShield is doing a good job since I think they have had some webinars with IMA Pune. About 14 to 15 webinars they have done in all over Maharashtra. For Pune, I think 5 to 6 webinars they have conducted. And they are emphasizing to initiate us for having digitalization in the medical field, because a lot of issues are there, medical legal issues and other issues about the prescription also. Sometimes the handwriting is not legible. It's better that we have digitalization so that the record will be kept safe also. And whenever the patient turns back, we at least know whether he is having any reaction of some medicine and what he has taken, because the patient sometimes closes the medical record and there's a big issue that time. And we can cross-refer also the patient. So I'll request Mr. Deepen Mehta, an active member of DigiShield, to just enlighten us what he has for us. Thank you. Mr. Deepen.
Yeah, thank you, sir. Thank you, Aarti Madam, Sanjay sir, for giving us opportunity and present DigiShield and organize this webinar. Basically, in current COVID situation, many of the doctors are doing video consultation or teleconsultation through WhatsApp and through any other many such media. So, but in India, 80% of the doctors are not into digitalization. So there are various challenges which doctors are facing to adopt digitalization in India. So one of the most and a major challenge is the cost. It requires huge capital to have digitalization in computers, laptops, internet, servers, etc. So many are small doctors or like doctors in the village area or small healthcare providers are unable to use the digitalization because of the capital investment. Even government has not made any format on any structure or no any complex, no any regulations to have digitalization for the doctors. Even it requires some technical knowledge, training for the staff, for the doctor to adopt the digitalization. Even the doctor's current writing of the prescription also changes if they adopt the digitalization. Various of the complexity and various other challenges, doctors are not able to adopt the digitalization in today's time. Even there are very rigid policies and it requires huge infrastructural cost as well. Even doctors are worried about the security and privacy of the records. So DigiShield can solve all these challenges and it's very easy to use application. Is there a solution for this crisis? Are we in position to restart India's healthcare system safely and effectively? No, how? DigiShield. So we have made one AI-based power solution special for current COVID situation, in which a patient needs to just enter 70 to 18 parameters of their health, of their diseases, their location history. So after entering all these details by the patient, our AI power solution will analyze the health data and location history of the patient, and it will give some intimation to the doctors whether the patient is of low risk of COVID or high risk of COVID. Because in current situation, you can see that the patient visiting to the doctor's clinic might be of COVID or not. So it's a risk for both doctor as well as for the patient. So through this feature, you at least doctor can get some intimation or security alert that the patient coming to visit his clinic is of high risk or is of low risk. So if suppose patient is of high risk and doctor can do consultation through telephonic or through video, so through digital, is it possible? And if the patient is of low risk or medium risk, and doctor feels that patient needs to have a in-person visit consultation, then even in-person visit can also be possible, and consultation also be possible, and doctor can send the paperless prescription. So what we focus on, security. So our entire patient medical record and everything is stored in secure cloud server. We are HIPAA compliance company. So even the employees or staff members are not allowed to use the mobile phone inside the premises. So the main challenge which doctor was also facing about the security or privacy policy of the records. So that is also solved by us. It is securely stored in the cloud server. Even doctor can get their access from their mobile from any of the any location and any time, which helps doctor to maintain a relation with the patient. If a doctor is visiting 1 to 2 clinics, can then through their login ID and OTP, doctor can log in to the application, and doctor can view the entire medical record of the patient whenever they require. And it's very convenient to open. If suppose a doctor's PC or tablet has been misplaced, or suppose it has been broken, so doctor can have their entire record in the new devices just by logging through their mobile number and OTP. Doctors can get their daily, weekly, or quarterly reports of their patient's history, the number of time patient visited, their previous medical records, then even the consulting charges or fees the patients pending or paid. So a complete analytical report of the patients is available for the doctors. The medical record is accurate and up to date. It is synchronized live through internet. So it is the record of the patients is accurate and up to date, which can be viewed by the doctor, and the entire record is saved in the secure cloud-based server. The entire record is backup in a Google Cloud. So many times it happens that doctor has given the prescription to the patient and have informed the patient to visit or follow-up visit after 3 or 4 days. So after 3 or 4 days, patient forgets the handwritten paper prescription. So in such cases, doctor find it difficult to provide them further medication. So through DigiShield, doctor just need to write the prescription, click the photo and upload it in the application. Patient will receive the SMS of the soft copy. So even after like 3 days or 4 days on next follow-up visit, patient forgets the prescription. Doctor can view his previous prescription, and accordingly doctor can treat and give the further medication. Various other features are there: teleconsultation, video consultation, appointment scheduling, online appointment booking, patient's medical records can be uploaded. Even for patient will receive the follow-up reminder SMS before 24 hours visiting to the clinic. We are also working on handwritten to text converted. So like suppose if doctor is using our tablet version of the DigiShield and is writing the prescription for 3 to 4 months. So through our AI-based solution, it will convert the doctor handwriting into the text. And the application is available free for the doctors through Android Play Store as well as iOS App Store. The software is very easy to use. We have the 2 versions of the software. One is handwritten tablet and one is mobile-based version. So handwritten tablet is basically doctor instead of writing the prescription on the paper, doctor can write the prescription on the tablet and it will be saved in the tablet and patient will receive the soft copy. And if doctor is using the mobile version, they just need to one-time registration of the patient. After registration, doctor can do video consultation or teleconsultation. After consultation, doctor just need to click the photo and upload it on the application, patient will receive the soft copy. Even in current situation, many of the doctors have seen that using video consultation through the WhatsApp. So would recommend instead of using WhatsApp, they can do through DigiShield. The benefit which doctor will get is the first is doctor will receive the digital consent of the patient before the teleconsultation. And after the teleconsultation, in many of the cases, what happened through WhatsApp, if doctor has done the consultation and patient has not paid the consulting fees to the doctor, so it's risk for the doctor about the consulting fees. So in DigiShield, if doctor has done the consultation and appointment booking has been done, but consulting fees is pending, so prescription will be sent by the doctor, but patient will not able to view, and it will be not generated until and unless the patient makes the online payment. Once the patient will make the online payment, then only patient will able to view the prescription, and the prescription will generated. So would recommend doctors to download the DigiShield and start using. It's free for the lifetime, and it's available both in iOS as well as in Android. So if you have any question, you can contact us, or you can also visit our website www.digishield.me.
Thank you, Dipen. You presented, I would say, in a very simple and lucid manner. And I request you, if you can have some good session for digitalization at IMA, so that you can teach also our doctors, those who are interested. A lot of things can be initiated so that they can go for whatever you say. As our Honorable Prime Minister has said, we should go for digitalization. So why not?
Yes, definitely, sir. I would be happy and would be a pleasure that I can have interaction with doctor and have the complete demo. And also not about the software, apart from software, also we can have some digital training or something.
If there are some issues, please, we'll have a talk with our President Madam, and after the appointment, we can fix up that date for our members. Thank you.
Yes. Thank you.
So, I request President Madam, should we go ahead for the next topic is by Dr. Advait Kothurkar, sir, Corona attacks on vascular system. So, Madam, please introduce sir and let him take over.
Yeah, yes, Dr. Advait Kothurkar, I'm very much pleased to introduce him. He is a vascular surgeon and he has done his MS, DNB, MRCP and fellowships in the vascular surgery from UK and fellowship at the Nizam Institute of the Medical Sciences at Hyderabad and Royal Victoria Hospital, Belfort, UK. He is a consultant vascular surgeon in KEM, in DMH, Dinanath Mangeshkar Hospital and Sayadri Hospital, Pune since 2006. And I request Dr. Kothurkar to present his views about the coronary systems affected by the COVID, how it is affected and how we have to take care of that.
Okay, right. So what happens is I'm just going to talk about corona attacks on the vascular system. See, the thing I was very surprised to see is that there has been a lot of research as regards cardiology and hematology and so many systems. So what happens is there's a lot of data, and as regards the vascular system, we do not seem to have so much data. So we've been facing this pandemic since the beginning of this year. And this is approximately what happened in March. That is how we looked before the pandemic actually started. And then after 31st of March, that was the state of affairs for most people. So what was happening in the world of vascular surgery? So till April, everything was fine. There was a movement which started off, which was called the Med Bikini. And this basically happened because there was a paper which came out in the Journal of Vascular Surgery in April, which talked about unprofessional behavior in vascular residents in the US. So there was a massive response from the residents and the consultant's side, where they said, why cannot we behave like normal human beings like everybody else can? And then eventually that paper was withdrawn. So everything was all hunky-dory till that time. And then in May and June, all hell broke loose in the world of vascular surgery. We found that there was an increased risk of severe COVID infection. So those patients who had a high vascular risk factor burden seemed to have a severe infection in COVID, and they also were dying more because of the COVID problems. There was a large number of reports and cases with myocardial infarctions and strokes. Especially, we were seeing them more in younger patients. So younger patients were developing MIs and strokes. And the whole thing that we still felt was that COVID seems to be a microangiopathy. So it tends to affect everything at the smaller level, at the capillary level, at the microvascular level. And we are never going to see macrovascular problems in COVID. And that's what our perception was. So we were a little bit skeptical as to whether we would do any work at all in this pandemic. But as we now see, we are doing more and more work with DVT, pulmonary embolisms, and arterial disease. So on the left, we see the prevalence of DVT is high, associated with adverse outcomes in hospitalized patients. And the study reports an overall 24% increase incidence of pulmonary embolism with COVID pneumonias, 50% in the ICU, 18%. So large number of venous thromboembolism as compared to arterial disease. So since what I thought was more relevant is to talk about what is happening in Pune. So I spoke to a number of our vascular colleagues in Pune and a few all over India, trying to get an idea as to what they felt. Now, see, we do not have data on this. Nobody's actually calculated numbers. Nobody's actually got all this data collected and presented it as papers. But what are our perceptions in as regards venous thrombosis? So our perception is, our experience is, there is a moderate increase in the rates of DVT as compared to before. So it's not a huge increase. There is a moderate increase in the rates of DVT. Some patients are presenting as DVT, and then you do their COVID workup and they turn out to be positive. The treatment protocols seem to be as per the current guidelines. So nobody in the world seems to have changed any guidelines as regards treating these patients with deep vein thrombosis and pulmonary embolism. There were more instances of distal DVTs. So what we found was it was more the popliteal and below that you had DVTs, which were present in mildly asymptomatic COVID patients. See, what you have to realize is those patients who were in the ICU were a different category, and I have not been able to include these patients in this group at all because I don't work in the ICU. And a lot of times the intensivist or the pulmonologist or maybe Samir were managing these patients in the ICU. But this is what we find in the non-ICU settings. There is a larger increase in superficial vein thrombophlebitis. So a lot of patients who have had varicose veins and come up with thrombophlebitis to me in the clinic or in the hospitals, we put them onto a small dose of newer oral anticoagulants as these patients are normally treated. And when we do their COVID testing, it turns out to be positive, or at least their antibodies come out to be positive, which tell us that they may have had a COVID infection in the past. Now, just regarding one hospital like Dinanath, we reportedly have a higher incidence of pulmonary embolism in the ICU settings. But what we feel is DVT and thrombophlebitis is not necessarily COVID-19, but we need to watch for venous thrombosis in COVID-19 and give thromboprophylaxis in admitted patients. So there are a few guidelines which came out as regards the chest expert panel, and I've got a summary of recommendations. So in the absence of contraindication in an acutely ill hospitalized patient, anticoagulation thromboprophylaxis is better over not giving any anticoagulation thromboprophylaxis. In critically ill patients, anticoagulation thromboprophylaxis is definitely indicated, and maybe treatment in case these patients have DVT and or pulmonary embolism. And those patients who are acutely ill hospitalized patients, we suggest anticoagulation thromboprophylaxis with low molecular weight heparin over unfractionated heparin. Now, the reason being, I think, in all this is to, when a patient is put onto unfractionated heparin, the nursing staff or the doctors need to keep on checking the APTT every 4 hours to make sure that it is in the therapeutic range. And that is why, to reduce doctor-patient interactions and spread of the virus, I think the low molecular weight heparin or fondaparinol has been suggested. It is recommended that inpatient thromboprophylaxis only over inpatient plus extended thromboprophylaxis. This is a factor which I think each hospital is deciding how they want to go about it. But there are some hospitals where they would get only inpatient thromboprophylaxis, whereas some hospitals like Dinanath would give them NOACs even post-discharge. For outpatient COVID-19 patients, you can use a newer oral anticoagulant drug, provided there are no major drug interactions. What about arterial disease? Now, we try to look up all the arterial diseases again, which have been published so far. And this seems to be in the Annals of Vascular Surgery published in August 2020. We've got the largest cohort here, 27 studies which they looked at. So we don't have a huge amount of data. And what they say is arterial thrombosis approximately happens in 4% of critically ill COVID patients. So the risk burden of arterial thrombosis is quite low. Again, very small data in press, radiology saying all patients undergoing with COVID infections have some amounts of venous arterial thrombosis. So what are our experience or perceptions in the ICU? Now, as regards the ICU, the incidence of arterial thrombosis overall in COVID patients is low. All references to the vascular surgeons, especially in Pune, from the ICU were from critically ill patients. So these patients were more or less either on HFNO or NIV, or the patients who were on invasive ventilation. Most of the thrombi were at the popliteal or brachial artery levels. There are increasing evidence now of arterial thrombosis coming up in the arch of the aorta. And what we see is that from the arch of the aorta, the thrombus embolizes into the distal circulation. We initially thought that it probably comes from the microvascular circulation up to the popliteal level, but there are some evidence now, especially we've also had a few patients where there have been arch of aorta thrombi or descending thoracic aorta thrombi, which have embolized into the distal circulation, and or the arms also. Thrombolysis, so all these patients who were referred to us from the ICU died of severe COVID disease. So these 4% of patients who are developing arterial disease seem to have a severe kind of COVID problems, and they are all dying. Thrombolysis attempted for 2 patients did not help the survival of these patients. So maybe we were able to salvage the limb, but we could not influence the survival of the patient. Surgery was not attempted on these patients as they were on invasive ventilation. See, with invasive ventilation, we are looking at almost a 90% mortality in such patients. And there were a lot of reports in COVID patients. And these reports initially suggested that there was a 20% mortality in patients who were COVID positive and underwent open surgery. So surgery was not attempted in these patients. One patient settled with heparin, however, died of COVID. Our experience or perceptions in non-ICU settings were, we operated 10 known COVID 19 patients. We had 6 embolectomies, out of which 2 eventually were amputated. So one was a late, and then there was another late presentation who came to us about a month after developing COVID, and he did well. There was one amputation. 2 patients were not in these counts as they refused amputation and were lost to follow-up. We did 2 bypasses for known COVID positive patients and 1 aortic stenting. We conserved about 5 patients, and 3 of them were just digital ischemia. So it is just the fingers or the toes which were ischemic. The embolectomies did reasonably well if they reached in time. But what we found in such patients was that the patients had severe ischemia at the time of presentation itself. So normally what we would suspect is that the upper limb would give us about 12 hours, 18 hours to allow us to do an embolectomy. But COVID positive patients within 3 to 4 hours had a severe ischemia, and the leg, hand or the leg were already irreversibly ischemic by the time they even reached us. So they had a severe ischemia in a very short duration of time. One young male patient presented with the aortic saddle embolus. One leg was completely ischemic and irreversibly ischemic. So we amputated that one and we were able to salvage the other one. He's still doing well. Follow-up is for the last 3 months now. One young female presented with an arch of aorta thrombus despite various interventions, whether open or endovascular. She lost the arm above the elbow. And there was one who presented, so this guy came from actually Belgaum, and he presented after a month of conserved acute thrombus, had severe wrist pain, and we did an embolectomy at the femoral and popliteal level, and he was the person who did quite well. The amputations were all acute ischemias, all died despite amputation. One bypass patient was diagnosed COVID after the surgery. The other had was known COVID positive, but was asymptomatic. So both of these guys did well. The aortic stent was for an aneurysmal descending thoracic aorta, required repeated interventions, and still is in the ICU, but not with pulmonary problems, with GI problems. The digital ischemia patients were diagnosed after admission. So we admitted them for digital ischemia and then sent off a routine COVID test, which turned out to be positive. So they lost their fingers or toe tips, but the hand was salvaged, just putting them onto heparin and prostacyclins. One patient was diagnosed as COVID on admission for an embolectomy. She once was diagnosed as COVID positive, did not want to undergo surgery, went home, we put her onto low molecular weight heparin. Sorry, that's not unfractionated, but low molecular weight heparin. We sent her home and she came back after 2 weeks and she said, my pain's gone away. So she settled down conservatively. So the inferences that we have with the arterial system is that COVID has a much worse prognosis when it is associated with arterial disease. Most of these patients do not survive. This is a more aggressive disease and it worsens rapidly. The survival with major arterial problems in COVID is poor. Arterial disease with mild asymptomatic COVID positive patients, they do well. The thrombus that we got out from these patients seemed to be more sticky. So this was a uniform observation all over India, that the thrombus is more sticky. So it seemed more like a sticky clot, and remote access like Fogarty. So you put in the Fogarty from the femoral and try to take it out from the popliteal. In most cases, the clot will move out, but this does not happen in COVID. It sticks to the wall of the artery, and you actually need to go back to the point where it is stuck and take out that clot also. So this makes us think that these clots are more fibrin rich. So that's about it. Thank you so much.
Thank you very much, sir, for a very excellent academic feast. I would say a lot have been said. Are there any questions?
That means involvement of the vascular system is a very severe complication of the COVID.
Yes, especially the arterial system, when it is involved. seems to
What is the early sign to diagnose the vascular system is involved? Is it only edema or ischemia or discoloration, change of color?
No, madam, I think the first thing that comes up is pain. So the
Pain.
patient
Yeah.
will initially complain of pain, and if we end up neglecting, because this is very common in the ICU scenario, that they end up saying, "हाँ नहीं pain होगा." They have these N95 and PP that they are wearing, and the common feeling is that these patients tend not to be looked after so well in the COVID settings in the ICU. So
Yeah.
if a patient complains of pain in that setting, we maybe should be looking at the pulse, looking at the whether there is a good capillary fill. And if the patient is not on unfractionated or low molecular weight heparin, they should be started on it immediately. So if we see it at that level, maybe we can
Otherwise, I'll just
prevent
call you
it
back
from
in 5
growing.
minutes.
We can maybe see it, prevent it from growing further.
Yes, but sometimes that is a major symptom of COVID, the pain.
Yeah.
But
No, pain in the,
yeah.
either the extremities or the abdominal pain. Because yes, I do know, because you have pancreatitis as a presentation of COVID. So you get a severe upper abdominal pain. But then we've also been seeing COVID patients who've had portal vein thrombosis and superior mesenteric artery thrombosis. So I think having a high level of suspicion that could this patient have arterial thrombus is something that I think will help us a lot.
Yeah. But anything patient complains, we have to suspicious of the COVID first.
I think so. I think so.
Yeah. Nowadays, anything, headache, neck pain, abdominal pain, dysentery, anything.
Absolutely.
Anything leads. Only weakness also gives the COVID positive.
Exactly.
Pregnant patient complains only weakness because they are on the hematinics and calcium and vitamins, and still they are having the weakness. So first suspicious is the COVID and they come positive.
Absolutely. So, I think we have to, especially as regards the vascular system, we just have to be paranoid about it. So the first question that we ask for all vascular patients is the patient COVID positive or not? Or could there have been COVID in the past? Because we're seeing a lot of that also.
And even patient on the cortisones, they get the edema of the legs. Yeah. That time also it is difficult to say what, because of what it is, this symptom is there. Yeah.
So I guess Dr. Aditi.
Yes, Dr. Aditi has raised a hand. She want to talk something.
She can speak actually. Dr.
Yeah.
She has asked the question, which molecule is preventive for arterial involvement?
I think typically aspirin is what we should consider for arterial involvement. And I think as a protocol, we are also adding in heparin or low molecular weight heparins. Because what happens is, I think, here we are looking at thrombosis, and the understanding of thrombosis in COVID positive patients is a little bit uncertain. We don't know exactly why it would happen. So it is best to what we now call as dual pathway inhibition. So you can give them ecosprin and a low molecular weight heparin.
Are there more incidences in varicose veins patients?
No, sir. We are actually not seeing any varicose veins patients coming at all. Most of these patients are probably sitting at home and wearing stockings.
Okay.
Can you advise some mild or moderate exercises to avoid these embolisms to the mild symptomatic or asymptomatic patients?
See, I think it is just sensible and simple logic. If you are COVID positive, you have a viral infection, you need to drink plenty of water, you need to do some exercise, you need to walk about at least. Just lying down in bed is again a risk factor for developing deep vein thrombosis and or pulmonary embolism. So keeping yourself well hydrated, just maybe walking around the room, doing whatever exercises that you can. Because of the extreme exhaustion, most of these patients will not be able to, do regular exercises. But walking around, maybe moving your ankles, calves, just maybe every few hours, I think will make a lot of difference. And if your D dimer is high, like Samir said, maybe you should be taking some kind of a low molecular weight heparin at home also, because you may be at a higher risk of developing deep vein thrombosis. And especially if you get cough, because a lot of, see, even consultants, I know two consultants who from Bihar who had COVID and were complaining of cough pain. So their D dimers were more than 1500, and then they electively decided to go on to Xarelto for a month or so. So people have taken such precautions also. So maybe if you feel that there is some pain in the calf and which is persistently there for a day or two, maybe you could take some anticoagulant on an OPD basis. Doesn't need have to be admitted.
And the patient with the comorbidity, can you put them on the low molecular weight heparin or aspirin?
See, I think you need to think about what you are trying to prevent and what your comorbidities are. There are various scoring systems which will tell us, like the Hasbled score system and things like that, which will tell us whether a patient is at a higher risk of developing bleeds. So if a patient is at a higher risk of developing bleeds, maybe you would want to give a lower dose of low molecular weight heparin. Like Samir said, maybe 10 milligrams of Xarelto, not more than that, or some aspirin. A young, fit, otherwise okay patient should be able to take a reasonable dose of Xarelto. So I would go by what the risk of bleeding is, trying to put them into some kind of a scoring system.
Yeah. Samir, I want to ask you that when we suspect the COVID and the test, we do the test on the 4th or 5th day. So before that, would you advise to do the this blood test?
Before you've proven that the patient has COVID? No.
After that?
Yes.
After the test is positive, you will advise to do the hematological investigations.
Yes.
Yeah. Yeah.
I
because,
have another. I have a question here by Vardhan Seth, who is saying, what is the percentage of patients recovered after DVT and lower limb gangrene? See, as regards DVT, I think these patients, if they don't have pulmonary embolism, they recover reasonably well. That is my perception on it. I don't have numbers. But lower limb gangrene patients are usually patients who are fairly sick patients on ventilators. In my experience, lower limb gangrene have not recovered in whatever patients I personally have seen. But again, as I told you before in my presentation, these are our perceptions. We have not collated into any kind of data. We are in the process of doing that, but we don't really have numbers to say. But arterial disease, definitely gangrene is a very, very poor prognostic factor. Samir, what do you think?
Yeah, I completely agree with you. And even the pulmonary embolisms, if they happen in patients who are already have a bad lung compromise, then they can be disastrous. Somebody who's
absolutely.
in ICU develops a pulmonary embolism, it's a big problem. Of course, now that we know most of them are at high risk, we generally put them on therapeutic anticoagulation, and therefore anybody who's on oxygen goes on to therapeutic anticoagulation. So we prevent PEs from happening now. Most of the patients would come in, those who are not on anticoagulation, or they may present with a DVT and PE.
Absolutely, absolutely. There is another question from Dr. Aditi who says, does supplementary molecules support in such cases? But I have not understood what supplementary molecules mean.
This vitamin, zinc, vitamin D, vitamin C, and some homeopathy.
Homeopathy, I can be reasonably sure. Actually, I trust homeopathy a lot in many other fields, but I can tell you that homeopathy does not work well for COVID at all. I can assure. In Jidanath, we've studied those who are taking arsenic album and those who developed COVID actually for patients who were staff of the hospital. And more than 50% of these patients had actually taken arsenic album. And even with some other molecules which have been touted, they have sort of failed. So I don't think if you have a big load of the virus, I don't think anything prevents you. It prevents you
Yeah.
from acquiring the infection.
yeah.
Maybe for
Only,
minor infections, it may work, but not for
yeah,
severe.
yeah. Only we have to prevent the load of the virus.
Yeah.
And for that, we have to be careful.
Yes.
Samir, can I ask you a question? Just offhand, just about COVID, not about hematology. Because he was treating a lot of patients and seeing a lot of patients in Dinana. So
Dinanath people are very good in COVID. Performance of the Dinanath is good.
So what I wanted to ask you is, if you had to tell your patients who come to you in the OPD, either your clinic or the hospital, that these are the things that you should definitely do as regards preventing yourself from getting an infection or reducing the viral load, what would you tell them to do? And I don't know what to tell them.
Asymptomatic people, you're right? Those who not acquired infection, you want to tell them what the best preventive strategy is?
Yes.
This is going to be totally my personal opinion, okay? But
absolutely.
Yeah. My personal opinion is that you must wear, this fomite business. I think we are all coming to realize that fomite is not something to worry, So you touch a surface and then, you acquire it. That is very less likely. Most often it is person to person. You're in direct contact for a while and you're not wearing an appropriate, mask. So I think what I have been doing so far is to wear a double mask. One which nicely and snugly fits you, not the the fancy ones, but I wear a surgical mask inside, and on top of that I wear something which is made of cloth, anything maybe, but a good nice preventive mask, and less sanitizing to a certain extent, not being crazy about it, but that, and just staying clean and washing yourself when you return home from your work. Most importantly, I think these get-togethers is what where you meet relatives who you don't know where they've been working. You all meet together, you are exposed, and that's one of the common reasons how people are acquiring infection. So I think it is just distancing as much as you can, and most importantly, I think it's the mask.
Nicely fitting mask.
Nicely fitting mask, and I prefer a double one, but that's my personal experience and my suggestion. I don't know.
And don't touch the mask frequently
don't
to
touch the
address
mask
that.
on your eyes and other parts of your face.
So everybody is having the
Everything else is, I think, secondary.
Yeah. The mask is the vaccine nowadays.
Yeah, correct.
Okay. Anything else? Can we conclude?
Yeah, we can conclude. Thanks a lot. The faculty members, Dr. Advait Kothurkar sir, Dr. Samir Malankari sir, and Hasmukh sir. Just he had some emergencies, so he had to go. Thanks again for, I would say, excellent webinar, and hope we interact together whenever possible. Thank you. Stay
Thank you all for accepting our invitation for the webinar and giving your valuable time for this. Thank you.
Thank you, ma'am. Dr. Advait sir, there is one more question.
Sure.
So if you want to answer.
Yeah.
So you can just quickly do the answer and we'll end up for the day.
For aspirin, how to calculate the 30 days in COVID patients?
So 30 days is, I'll take that one. 30 days is from the time of discharge. When you're infected, you are on the aspirin anyways. So it is either from the date of detection of the infection or from the date of discharge. So 4 weeks is just an arbitrary figure. You could even make it 6 weeks. Little bit plus and minus doesn't matter.
Thank you.
Okay.
Nice, sir.
Thank you.
Thanks for your great efforts. Thank you.